From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello, and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and host of this podcast episode. In most countries around the world, there are no universal standardized guidelines for skin cancer screening. However, in Germany, since January 2008, men and women aged 35 and over who are covered by statutory or private health insurance are entitled to a visual whole-body skin examination every 2 years. Yet despite the scale of this national program, there's been limited evidence that it has reduced melanoma mortality in Germany. In a new study published in JAMA Dermatology titled Population Skin Cancer Screening and Melanoma Mortality Rates, the authors examined melanoma mortality trends from 2009 through 2022 in Germany and compared them with trends in 9 neighboring countries that do not have population-based skin cancer screening programs. In this episode, we discuss what the authors found and what the results may mean for skin cancer screening research and policy. You can find a link to the paper in this episode's description. With me on the podcast, I have Dr. Joachim Hübner, an epidemiologist who works at the Agency for Clinical Cancer Data of Lower Saxony in Oldenburg, Germany. He's the first and corresponding author of this study and is here with his co-author, Dr. Alexander Katalinic, who is a general physician and professor of epidemiology at the University of Lübeck. Both are here to discuss this really interesting and important work. Welcome to the podcast, Drs. Hübner and Katalinic.
Thank you very much. It's an honor to be here. Thanks for the nice introduction and welcome to all the listeners.
So before we jump into the podcast, questions related to your study, can you tell the audience a little bit about each one of you? I'll start with you, Dr. Katalinic.
I'm the head of the Institute for Social Medicine and Epidemiology at the University of Lübeck. I'm a physician by training and also developed in the last 25 years to an epidemiologist. And I'm accompanying the skin cancer screening in Germany for many years. Also, a big study, the SCREEN study, was performed in our federal states. And maybe we can talk later a little bit about this topic.
And Dr. Hübner?
Yes, I am the head of the small institution Agency for Clinical Cancer Data of Lower Saxony. And how I am concerned to the topic, I was for about 11 years at the Institute of Alexander Katalinic. He was my boss, and we did some projects on this topic. In my daily work, there's little concern with this topic, but it was a pleasure to do this project together on skin cancer screening.
Yeah, and I want to add that Joachim and we both are working currently on the 3 guideline on skin cancer prevention. And in this guideline, also skin cancer screening plays a very important role.
Yes, skin cancer screening is something that has been hotly debated across many different countries here in the United States, Australia, and Europe as well. And I would say Germany has been an exception in its pursuit of having population-based cancer screening. And a lot of this started off with the German SCREEN study back in the early 2000s. And I know, Dr. Katalinic, you were very heavily involved in designing and deploying that study. Would you mind telling the audience a little bit about that study? It really informed policy around skin cancer screening in Germany.
Yeah. As you mentioned before, this SCREEN study was performed more than 20 years ago, and it took place in the federal state of Schleswig-Holstein, which is the northernmost federal state in Germany, with a population of about 3 million inhabitants. And in our region, we trained more than 1,000 physicians for skin cancer screening. And after this very intensive screening, the screening began for 1 year. And the screening was accompanied by very massive awareness campaigns. So we had in the end a quite good participation to the screening. We could examine more than 350,000 persons. And we saw effects of the screening. We detected a lot of early melanomas, also basal cell and squamous cell skin cancers, and they had a quite favorable stage. And this was the first result, I would say, which finally led to the introduction then of the national skin cancer screening. But we also saw some effects on melanoma mortality. In Schleswig-Holstein, it went down while it didn't went down in the surrounding countries. And this was I would say, a part of evidence that skin cancer screening might work. Later on, we did also some simulation studies like a natural history model, which is also published. And this confirms if you do skin cancer screening with good quality, accompanied by, I would say, awareness campaigns, then you can reach good results. But this might not be true all over Germany or in the current situation.
And so then you decided, based on this favorable outcome from the screen study, or the German government decided to adopt skin cancer screening as part of a regular kind of checkup. Can you explain to the audience that might not be familiar with the health insurance landscape of Germany, like how that get rolled out? And maybe Joachim can explain.
In Germany, there is an institution. It's called the Joint Federal Committee. And this committee decides on what is covered by the statutory health insurance and what is not. Most people in Germany are in the system of the statutory health insurance. There are also private insurances, but they are only available for some of the Germans. Sometimes it depends on the income, for instance, but about 90% of the Germans are in the system of the statutory health insurance.
You set a cutoff for screening for 35. Was there an upper bound of people that, maybe would age out of screening? And also, why did you choose every other year? Why not an annual screening, which is, I would say, traditional in how many dermatologists think about screening for skin cancer?
To be honest, I don't know about that. I don't know why an interval of 2 years had been fixed. Might have been 1 year. Maybe they calculated the costs. And
if I would take the answer, I would answer, in Germany, we have a long period common health check. It's called Checkup 35. And this was running now for decades. And I think the idea was to attach the skin cancer screening to this checkup program. So if you go to the general physician, then you can do the checkup 35 and then add the skin cancer screening. I think this was not a scientific decision to do it in a 2-year frame. It was more a feasibility of the screening.
Yeah, like a programmatic decision. And were these skin cancer screenings always performed by general physicians, or were any of them performed by dermatologists?
The people had two opportunities. They can go to the general physician and he does the skin check. And if the general physician then finds something unusual, then he will send the patient to the dermatologist. But it's also possible for people go directly to the dermatologist. So there are two ways. And I would say about half of the screen is using the way directly to the dermatologist and the others go first to the general physician.
I would like to add an important aspect. In the screen project, if the first examination was done by an GP or a non-dermatologist, to be more exact, he had to refer the patient to a dermatologist, not only if there was a suspected lesion, a malignant lesion, but also if the patient had any risk factor. And this is no longer the case in the current nationwide skin cancer screening. Of course, if there is a suspicious lesion, the non-specialist has to refer the patient to the dermatologist, but not just because there is a risk factor. In contrary, the risk factors have no meaning within the current screening. the patient is not asked if there is any risk factor. I think this is an important difference between the screen project, the pilot project, and the current screening.
Thanks for adding those details. I think that is very important to show that distinction. So, while the screen project did motivate reasons why Germany decided to expand access to screening, the screen itself, the visual examination itself, that process seems like it was a little bit different in the screen study than it is in reality now in Germany. I want to pivot to the study itself and how you designed it. I would say that it's a fairly straightforward design over a long period of time. Dr. Hübner, would you mind explaining how you set up the study and what did you think that you would find?
Alexander Katalinic just mentioned a study he did as a principal investigator related to the screen project. He compared the trend of melanoma mortality in Schleswig-Holstein, where the screen project took place, to the trends in melanoma mortality in the adjacent neighboring regions. And we now replicated exactly this study idea. It's an ecologic study. We have no information about screening of individuals. We don't need it. So we get data from the official cause of death statistics for Germany, and we assumed that the decline we hoped for to see of melanoma mortality would not begin before 2009. And we compared this to the trends in the neighboring countries. And of course, we hypothesized that if the screening is effective in reducing melanoma mortality, then we should see that the trends are more favorable in Germany compared to the other countries. That was what one should expect to see, but it was not the case.
Yeah. What did you actually find?
We found that if you look over the whole period.
And that whole period, you mean 2009 till 2022?
Yes, exactly. We found an average decline of melanoma mortality by an average of about 2% per year, both in Germany and in the neighboring countries. There was no advantage for Germany. On the contrary, if you look at the point estimates, the decline was even a little bit more stronger in the neighboring countries than in Germany. Of course, somewhat surprising if you come from the idea what a screening should do.
Dr. Katalinic, were you also surprised? And how would you put these findings into context? Why do you think it didn't show any mortality benefit after the introduction of the nationwide screening program?
To be honest, I wasn't surprised. I wasn't surprised because we have a long discussion within Germany on the skin cancer screening. We also have a kind of working group on skin cancer screening and also a small society which takes care of dermatological prevention. And within this, colleagues and I, we discussed a lot of this. And we think that the current screening, how it is performed in Germany, also when you look on the participation rates, then you will see, you can conclude that the effects of the screening could not be very large. We have a participation rates of about 30% within 2 years. That is the first point, and I think it's much too low to see really large effects on mortality. And the second point is that we have no quality assurance in Germany of the skin cancer screening. We know nothing about quality. And we assume, and also colleagues assume this from the dermatology associations, that the quality is not that good. And the third point is we don't know which persons are going to the skin cancer screening. And it's very likely that you have more healthy persons. That's what, as an epidemiologist, I would call it healthy screening bias. And if you count this all together, then I was not very surprised to see this result. one has to conclude that the German skin cancer screening on the population level is not fulfilling its expectations.
And so then where do you go from here? Is it that you need to just crank up the participation rate? Do you need to better target high-risk individuals? Should the program be abandoned altogether because it doesn't seem like it's worked? What should you take from it?
At first, I would say if we would continue in Germany the screening how it is, it should be abandoned. That wouldn't be my first conclusion. But I see many options to improve the screening. And it's not the participation rate. This might be an idea, but you see, it's almost not feasible to reach in a big country like Germany, and I think it would be the same in the US, to have a participation rate of 70% of the population. You don't have so many physicians to do this. And also the dermatologists, 20 years ago, they said, we can screen all Germans, but they won't say this today. This is not realistic. And so we have to conclude that we need a more targeted screening. This is a risk-adapted screening. And I think more and more physicians and health authorities looking on this idea of a risk-adapted skin cancer screening. And I'm convinced that if we can move the screening to a risk-adapted screening, we will have better results, because you can show, and there is evidence, that if you do a very good skin cancer screening with a high quality, then the patient will have some benefit of such a skin examination.
And Dr. Hübner, where do we go next with this research? Or is this, purely just setting the stage for kind of a temperature check of where we're at with this program? Or is there another piece of work that you may be working on trying to better understand, what happened?
Yes, I think most important would be to know why the performance of the current screening is so poor. And Alexander, if you allow, in one point, that we are not of the same opinion. We disagree because, as we discussed, after the screen project in Schleswig-Holstein, we could observe a decline in mortality. And I wonder why we don't see this as a nationwide. This is a question I have no answer. For. The participation rate was about 19%, and it was only a 1-year project. And now we have a participation rate of about 30%. If you look at the 2 years interval, and we don't understand. Alexander mentioned it. There was an awareness campaign in Schleswig-Holstein, and it might be that this campaign is responsible for most of the effect. And the risk factors were very important within this screening, but they are not important in the current screening. And it may be that persons at risk took part in the screening in Schleswig-Holstein, but now they do not. And that gives us hope that the performance would be better if we are successful in getting this person. May I remember a study, Alexander, we did together about 10 years ago. And we investigated several approaches of a risk-adapted screening. We had this data from the screen project, and where screen factors were fixed. And we could see that if we screen only people that had at least one risk factors, we would only screen 20% in comparison to a general screening without looking at risk factors, but we would get 80% of the melanomas. And this, of course, would be better. We must not forget that there are also harms of screening, as overdiagnoses and anxiety caused by false negative test results, and the costs and the use of healthcare resources. This is all important. So risk-adapted screening might be a good idea for the future, and the Joint Federal Committee, just mentioned, will be tasked to revise the skin cancer screening and consider the possibilities of a risk-adapted screening. We will see what the decision will be. It is expected at the end of next year. and then we will know it better.
So I want to thank you so much, Joachim and Alexander, for being on the podcast and for sharing your expertise and insight on this really important topic, controversial topic, a topic that we need more data about. And I know there's a lot of people around the world that are really interested in this conversation and the science that is yet to come. So I'm Dr. Adamson, and I've been speaking with Doctors Joachim Hübner and Alexander Katalinic, both about the population skin cancer screening and melanoma mortality rates in Europe. You can find a link to the paper in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.